Well, good morning, everybody. It's great to see so many of you or to join with so many of you. And are you able to give me a thumbs up? If you can hear me, perfect. I thank you so much. I was just having some last minute internet connectivity. I noticed I was the only person moving on my screen. Everyone else seemed frozen in time. So I'm joining you through a phone hotspot. So thanks everybody for joining us. So welcome to the third annual MacGlObAS joint grand rounds between the Department of Surgery and Anesthesia and Obstetrics and Gynecology. I am just going to adjust my screen here. So as you know, MacGlObAS is a new collaboration or fairly new collaboration between the McMaster University Global Health Office and the Departments of Obstetrics and Gynecology, Anesthesia and Surgery. And the purpose of MacGlObAS is to bring together faculty and residents to promote our activities and partnerships, recognize and inspire volunteer service by faculty and trainees, and to develop educational resources for those interested in global surgical care and to generate innovative interdisciplinary research. And David has all of our links to join us there. And MacGlObAS recognizes and acknowledges that McMaster is located on the traditional territories of the Haudenosaunee and Anishinaabeg nations. This territory, covered by the Upper Canada Treaties, is within the lands protected by the Dish with One Spoon Wampum Agreement and is directly adjacent to the Haldimand Treaty Territory. And we're so privileged today to have with us Dr. Dylan Bold. Dylan was going to join us last May, but things were somewhat turned upside down by events in our world. And we're so happy that he can join us virtually today. So Dylan is an associate professor in the Department of Anesthesia and Pain Medicine and the Department of Innovation and Medical Education at the University of Ottawa. He trained in anesthesia at University College London and did fellowships in medical education at Toronto's St. Michael's Hospital, pediatric anesthesia at Sick Kids, and pediatric cardiac anesthesia at Great Ormond Street Hospital in London. Dylan has helped to develop the University of Zambia anesthesia residency program in 2011 and continues to be involved with this. This program trained the first anesthesiologist in Zambia since independence in 1964. Dylan's also the chair of CASIF, which for those of you who don't know, stands for Canadian Anesthesiologist Society International Education Foundation. And this organization has partnerships to support residency education in anesthesia in Rwanda, Ethiopia, Guyana, and Burkina Faso. He sits on the education committee of the World Federation of Societies of Anesthesiology, and he recently returned from a sabbatical year in Rwanda, where he was working with the Department of Anesthesia, Critical Care, and Emergency Medicine. And the other thing I should mention that's not on this bio is that Dylan is the recent recipient of the 2021 Canadian Anesthesia Society Humanitarian Award, which is given in recognition of excellence in global anesthesia. So congratulations, Dylan, for that. So this morning, Dylan is going to talk to us about partnerships, and he's going to talk to us about partnerships to develop capacity for global surgery and anesthesia. So thank you so much to all of you for joining us, and Dylan, please take it away.
Thank you. Can you hear me okay, John? Hopefully you can see my screen. Thanks very much for the kind words and the introduction, and thank you also for Joel and to Anne and for everybody else for inviting me to come and speak. It's a real privilege, and I'm honored to be invited. As Joel said, originally this talk was going to be in May last year, and the title of the talk was simply going to be Global Health Partnerships. And now obviously the talk is Global Health Partnerships in the time of COVID. And as with everything in the pandemic, there's really nothing good about the pandemic. nothing good is happening to partnerships with global surgery and global anesthesia because of the pandemic. But I think there are some really important teachable moments that I'd like to focus on over the next half an hour or so. And then we'll have I think, a good 15 minutes or so for questions and discussions at the end. I think the main themes that I want to touch on are some of the collateral damage. I think in any crisis, like a pandemic or any other kind of crisis, you have the harm from the crisis itself, so here from the COVID, but there's also a good amount of harm from everything else around the edges. The need for global surgery hasn't gone away, and I think that we know very well from the situation in Ontario what's happened to waiting lists when operating rooms have been shut down. I think you can only imagine in countries that were already struggling to manage even urgent and emergent surgical and obstetric work, how badly their healthcare systems have been damaged, and how behind, how much collateral damage there's been. I think the other key thing that I'm going to talk about over the next 25 minutes, half an hour, is about healthcare systems. And I think it's become very obvious to us how vulnerable even our own healthcare systems are, but even more so how vulnerable healthcare systems are in the poorest countries of the world. And I think that the key theme for me today is how we really need to think about building back better. We're all trying to get over the pandemic. We're very focused on vaccines and vaccine equity, quite rightly. These are the issues of our times. But fundamentally, healthcare systems are broken around the world. This is one of the main reasons why the pandemic has been so devastating. And we need to think about the long-term background chronic problems as well as the acute crisis. Okay, so this is section 1, activity for maintenance of competence. Just going to speak about conflicts of interest, and really these are two organizations already introduced in the bio. Thank you for that. I am the chair of the board of trustees of both of these charities right now. I'm handing over the chair of CASIEF just next month. GADP is a UK-based organization that supported the first anesthesia residency program in Zambia, and really the kind of partnerships that I've been, I've been very focused on. I think that everybody involved in this program, and it's like all partnerships, a very collaborative effort with most of the hard work being done by our partners in Zambia. We're very proud of what it's achieved. And from never having trained a physician anesthesiologist in Zambia since independence, or in fact, even before that, there's now a thriving residency program. We've just opened a second training site in Ndola outside the capital in Lusaka. There's a Society of Anesthesia of Zambia. And I think most important, real leaders in anesthesia. And I'd just like to give a shout out to Masuzio Ziambo here that I'm showing on the picture, who was one of the graduates of the second year of this program, who's actually speaking at the Canadian Anesthesia Society meeting next month for those of you in anesthesia who are planning to attend that at one of the sessions there. And he's been the COVID intensive care lead for Zambia throughout the pandemic. And I think that it's been amazing for me to see how well he has dealt with incredibly hostile conditions in the intensive care during COVID, and how well the training has equipped him for that. I think it speaks to how the pandemic has made us realize the value of many aspects of global surgery and anesthesia and critical care, which were perhaps underappreciated in the first place, and how much healthcare systems would struggle if they didn't have people like Masuzio, leaders who have been trained through programs like this. CASIEF has very similar programs in, as Joel said, in Rwanda, and more recently in Ethiopia and Guyana, very focused on long-term commitment to building capacity through education. So I'd like to go back to COVID, and I think that we've all heard about the devastating second wave of COVID in India. And I'd like to highlight this one story which really shocked me, of a journalist now deceased who live tweeted his hypoxic deterioration from COVID, his being turned away from 3 hospitals, unable to find an institution with doctors or oxygen or any kind of treatment, and unfortunately died in the process of live tweeting his search for oxygen and medical care. The situation in South Asia now is really quite horrifying, with descriptions of wards with very few staff, more dead patients than live patients, patients dying in hospital corridors, on roads, and in their homes. Crematoriums in Delhi have run out of firewood, with special ordinances for city trees to be felled so that there can be enough firewood to have public crematoriums to bury the dead. I think this kind of image and this kind of narrative is obviously deeply shocking and should be deeply shocking. I think, taking us back to the beginning of the pandemic, we here in Ontario looked abroad to places like Lombardy in Italy and to New York with real fear that our healthcare system would collapse in the way that the healthcare system seemed to collapse in places like New York and Lombardy. Now, looking at South Asia, we're really seeing healthcare systems completely implode in a devastating way. And I think that what I want you to do through the rest of this talk is to hold on to a little bit of that shock, and a little bit of that feeling of wanting to reach out and help and do something. Because I think that there are a lot of things going on in the background, a lot of long-term problems that we perhaps are less aware of, that fall off our consciousness and our radar, that we should be as equally shocked about. But we're not, because because of the way crises work. We tend to focus on short-term things, and we tend to focus on the thing immediately in front of us. So this is the current situation with deaths, cumulative worldwide deaths from COVID, with the different colors on this graph being continents. And despite enthusiasm about vaccines in Canada and the US, I think it's very, very obvious that the pandemic is not going away very soon, and things are continuing to deteriorate throughout the world. I think the other thing that we can see looking at this graph is that the pandemic has affected every continent and obviously respects no borders. And I think that it has made us realize how interconnected we are. There's been, I think, a lot of discussion, again, quite rightly, about how we're not safe until everybody's safe, about how we need to have vaccine equity, and that if we allow COVID to continue in places like Brazil and India and South Africa, unchecked without public health and vaccine control, then it's a hotspot for variants of concern, which are just going to come back and threaten us in North America. So there's very real reasons why we here in North America need to think globally about the pandemic. But I'd like to say that it goes beyond that, because the vaccine issue, while probably the most important issue of our time right now, I feel is just a symptom of weak healthcare systems globally. It's not isolated, but part of a larger picture. And what we really need to be thinking is how we can strengthen healthcare systems globally and build back stronger after COVID, so that the world is better prepared for future pandemics, which will doubtless come. You see that the line at the top in yellow of Africa is by far the thinnest line. And this map of the world showing daily new COVID deaths per million people from just a couple of days ago, makes it look like Africa has been relatively spared by COVID, which I think is one of the dominant discourses. But I'm not sure that this is true. And certainly when I speak to my partners in Rwanda, Ethiopia, Zambia, and other countries, the situation is very, very different from how it's been described in the mainstream media and even in the peer-reviewed literature. There's simply not enough data. One study that struck me was that at UTH, the University Teaching Hospital in Lusaka, a team did nasal swabs in the mortuary, nasal PCRs on all patients who had died. And this was about September last year, when official figures suggested that there were only around 300 people who had died in a country of 15 million people of COVID since the start of the pandemic in 6 months at that time. But when they tested nasal PCR for the patients in the mortuary, they found that 20% of the patients in the mortuary had COVID. And in fact, when they went back and spoke to the families, the symptoms that they had before they died were entirely consistent of them dying from COVID-related disease. And I think that really the situation in sub-Saharan Africa is more one of absence of evidence than evidence of absence. There's simply not enough testing. People don't really know what's going on, especially in the rural areas. And I think that healthcare systems there have also been hit very hard by COVID. So the thing for me is that problems with the response to COVID, whether it's lack of hospital beds, lack of ventilators, lack of oxygen, lack of drugs, lack of doctors, is none of these things are isolated. They're all part of a failure to invest in healthcare systems. We realized here in Ontario how potentially vulnerable our healthcare system was, but things are just at a completely different level in South Asia right now. But I'd like to take things further and think about countries like Rwanda and Ethiopia and Zambia, where we have had our global surgery, global obstetrics anesthesia partnerships with. And the reality is that those countries had healthcare systems that were failing to deal with endemic disease way before the pandemic. Their healthcare systems were already so weak and underdeveloped, or and parts of the healthcare system almost absent, that even the day-to-day trauma, obstetric care, general surgical needs were not being met. But I don't think that that has been on the consciousness of the world anywhere near as much as it should have been. I'd like to launch just a quick poll about one specific example. So David, if you could launch this poll for me just now, please. I'd like to ask the question of, if you could think of global deaths annually from pneumonia, how do you think the number of those deaths compare with the total number of deaths we've had from COVID so far? So do you think it's about the same number from pneumonia as the deaths from COVID, more or less? And there's a few different options there for more or less. And I'll just wait a few more seconds because it looks like a few other people could still have the opportunity to vote. Okay, let's close the poll at this point. And I think you can see the results. Actually, maybe I primed you too much, because people have, a lot of people feel like probably the number of deaths from pneumonia is the same or more than the number of deaths from COVID. But actually, there's a lot of variation in the answers. Could you close that poll now for me? David, oh, there we go. Trouble getting rid of the poll on my screen, but yeah, I think I can advance my slides now. So actually, if you look at the number of deaths year by year from pneumonia worldwide, since 1990 to the current day, between 2.5 to 3.5 million people die each year from lower respiratory tract infection alone. There's been some progress, but not very much. So we're talking about around 60 million people who have died from pneumonia in the last 20 years. And actually, the majority of those deaths are preventable. And you might ask, what do I mean by this? In Peacetime, published last year, showing data from before COVID, Arthur Kwizera and colleagues from Kampala in Uganda found that almost 5%, 1 in 20 of their admissions to the emergency department in Kampala were in acute respiratory failure. These patients were young, with a median age of 38 and median pulse oxygen saturation of 77%. Very, very sick patients turning up, almost kind of like COVID levels of patients in peacetime before the pandemic. 85% of these patients were dead at 90 days. Why the shocking mortality, and why would they see these kind of levels? Well, what's happening to these patients when they arrive at the emergency department? If they do reach a hospital, which many won't, that will die at home or fail to reach definitive care, the reality is that these patients find what's been described very eloquently by Paul Farmer as a clinical desert. Often a lack of therapeutic care, oxygen, doctors to look after them, and really symptomatic of a weak healthcare system across the board. When I worked in Zambia in the operating room, we got an oxygen monitor and tested the pipeline oxygen coming out of the wall and out of cylinders, which had not been tested before and was not regularly tested by biomedical engineers. You can see the number in the image on the bottom right. And we found that the oxygen concentration coming out of the wall that was meant to be 100% oxygen was between 50 and 70%, depending on the day. This is not an isolated issue, but symptomatic of a very, very weak healthcare system, from poor procurement and supply chains, poor information technology, inadequate systems of referral, desperate shortages of staffing, and facing the world's highest burden of disease and surgical disease. So why are these deaths, why is not more done about this mortality? Why are these deaths not on our radar? The reality is, like most of the stuff that affects us in global surgery and global obstetrics, is that it's almost entirely due to where these deaths occur and who these deaths are happening to. And you can see from this heat map for where most of the global deaths from pneumonia are, that the reality is that they're mostly happening in sub-Saharan Africa. And this is not just an issue with oxygen. I think we all heard reports of running out of drugs in Brazil, in Manaus, and in Sao Paulo, and many other cities, where there were reports of seriously ill patients being intubated with just neuromuscular blockers without any sedation. Patients who were awake and terrified and paralyzed so that they could be intubated. Here in Canada, we had a scare with succinylcholine, where at my hospital, we had to adjust our use a little bit so that we didn't run out of one neuromuscular blocker, but we never did. When I worked in Zambia, we found that the propofol that we were using seemed to be very ineffective and not doing what we expected to do. So I brought some of that propofol back to Canada. We put it through a mass spectrometer and published these results. We found that the active ingredient in the propofol bought in bulk by the Ministry of Health was around 45 to 50% of the expected active ingredient in 1% propofol. So patients for sedation and for anesthesia will routinely be given half-strength propofol. And unfortunately, this issue of substandard or counterfeit medicines is, again, by far from an isolated situation, and is really symptomatic of weak healthcare systems, weak regulation, weak leadership in government, procurement. This is there we go. This is a picture that I took from a sign that was up on the wall when I was living and working in Rwanda. The first day that I worked at the teaching hospital in Kigali, a woman died postpartum, and when the team tried to resuscitate her, they were unable to give her adrenaline. They were unable to give her epinephrine because there was none in the hospital at the biggest tertiary referral center in the whole of the country. We'd routinely run out of all opiates, all muscle relaxants. And there would be days, as you can see, where there would be almost no size of endotracheal tube appropriate for most children, despite the fact that we had the only one single fellowship-trained pediatric surgeon in the entire country working in that hospital. In the UK, Rupert Pearce, who works at the Royal London Hospital, noted here on Twitter about how intensive care nursing ratios had fallen from 1:1 to sometimes 1:3 and 1:4, with really untrained or poorly trained people filling those gaps. And that's something that we've seen even here in Ontario. In Zambia, we looked at all medical and surgical admissions to the hospital over a relatively short period of time, and looked at what proportion of them actually met criteria for a critical care referral. We found that 45% of all admissions to that teaching hospital, which has 17,500 acute admissions a year, met criteria for ICU referral. A quick back of the envelope calculation suggests that this would be about 8,000 patients a year needing critical care referral. Sadly, the reality is that that hospital had at the time 8 intensive care beds with ventilators, and the whole country had just over 100 intensive care beds. And the mismatch between what's needed in terms of beds, ventilators, nurses, intensive care doctors, and the demand in peacetime, day to day, year after year, decade after decade, it's just an enormous gap between what is needed and what is available. So this idea of flattening the curve has entered into common lexicon, and everybody that we know, our non-medical family members and people on the street know about how we need to flatten the curve of COVID so that we can get control of the situation. But of course, when we think about the curve, we need to step back and realize that the curve only exists in relation to a constant, and that constant is healthcare system capacity. The constant can be increased in surges, as we've done in Ontario. You can increase your healthcare system capacity in certain areas if you need to, but only to a certain level. We saw, we've seen that in many places in the world, COVID has breached this line and the healthcare systems have been overrun. But the reality is, in places like Ethiopia and Rwanda and Zambia and Uganda, this constant of healthcare system capacity is so low that it's not just beneath the curve of COVID, it's beneath the curve for endemic and epidemic disease happening year after year, decade after decade in that country. It's below the curve for mothers with obstructed labor needing a cesarean section, for patients with trauma needing urgent orthopedic surgery, with patients needing a laparotomy, with all patients needing critical care all the time. So what do I mean by a healthcare system? These are the 6 WHO building blocks for the healthcare system. And every single one of these building blocks is implicated in the failures I've been talking about. So for instance, the failure for oxygen delivery is due very much to inadequate financing throughout the healthcare system. Leadership governance is a huge problem with very weak systems of regulation, quality control of all drugs and medical equipment. There's weak supply chain issues, cold chains for vaccines, oxygen, drugs, or other technologies. Incredibly weak human resources for health, which is mainly what I've been working on. Very few biomedical engineers for operation and maintenance of oxygen supply systems. They are sometimes poorly trained and usually poorly equipped. Very poor information systems. Sometimes the reality, I saw patients die for lack of oxygen when oxygen failed during cases during the night randomly, both in Zambia and in Rwanda. And often the hospital leadership would not even get to hear about it. The biomedical engineers would have no idea because the interface between clinical medicine and the biomedical engineers was so poor due to weak information systems. And obviously service delivery suffers as a result of all of these things. So when we look at the situation, there's really 2 worlds, the world on the left and the world on the right. And the world on the left is a heat map that shows a measure of healthcare system capacity here, COVID-19 vaccines, and we can see the terrible situation with current vaccine equity where many countries in sub-Saharan Africa have received and given less vaccines than have been disposed of by pharmaceutical companies in North America. On the right, we can see a measure of burden of disease, and here are deaths from pneumonia. And you can see that these 2 images are basically just mirror images of each other. Instead of COVID-19 vaccines, we could as well show an image for pneumococcus vaccines, because many of these deaths from pneumonia could be prevented with pneumococcus vaccines, which are also delivered way less often in sub-Saharan Africa than they are anywhere else in the world. And you can look at really almost any map which shows a measure of, on the left, healthcare system capacity, and on the right, a burden of disease. And you see almost the same kind of images. It's the same thing happening again and again, either extremely low numbers or even lack of data on the left with physicians per capita, the main thing that we've been working on with CASIF and GADP, training specialist physicians, and on the right, a measure of maternal mortality. Hospital beds versus newborn mortality. And you get to feel like you're just seeing the same map again and again. And in fact, that's pretty much what it is. Sorry, I went one slide too forward. If we sum it up by healthcare spending per capita, just investment in the healthcare system, you can see, like all the other maps, it's the very same picture of the lowest investment in sub-Saharan Africa. But the global burden of disease is by far highest in the poorest countries of the world, mostly in sub-Saharan Africa, but also in some places in South Asia, with the global burden of surgical disease being particularly neglected. This is perhaps a busy and slightly confusing slide, so I'm going to take a few minutes to talk through it. And what this graphic shows is, in fact, the global burden of disease. Each one of these rectangles is a disease or a type of pathology, and they're color-coded. So all of the diseases in blue are what are termed non-communicable diseases, like cancers, ischemic heart disease, stroke, asthma and respiratory diseases, mental health. On the bottom right in green is basically deaths and disability adjusted, and years lost to disability from trauma. And on the top right in the kind of pinky red color are the kind of things that we think of most often as developing world, low-income country diseases, infectious diseases. They also put neonatal and maternal disease, which largely needs obstetric care to resolve in here, but things like HIV and malaria and tuberculosis. So I've highlighted pneumonia, lower respiratory tract infections, and I think it just goes to show that even this pathology that's responsible for so many deaths year on year, and really compared to the number of deaths of COVID is a really large contributor, is still quite a small part of the global burden of disease, of basically endemic and epidemic disease. How much of this disease is, in inverted commas, surgical? And it's really hard to say. It's been estimated that about a third of the global burden of disease needs surgical care or surgical infrastructure to be able to manage it or be able to treat it. Within the non-communicable diseases, it is largely care of cancer that needs surgery. Obviously, maternal care and newborn care can't be resolved without good obstetric care. And trauma is a huge number of these deaths and years lost due to disability. But when we look at the investment in different pathologies, there's really quite a shocking picture. The global burden of disease is the same image on the left. The bar chart on the right shows billions of aid dollars invested in healthcare globally. The pink bar is not all of the diseases that you see on the global burden of disease. It's just on its own HIV, TB, and malaria. Whereas the blue bar is all of non-communicable diseases. And in fact, investment in surgical care and in strengthening healthcare systems is probably even lower than it is in non-communicable diseases. So I'd just like to take a moment and come back to global health partnerships. And I'm going to share with you a short video that shows the kind of work that we've been doing in Rwanda.
Where would you even?
Sorry, I just need to make sure that I've shared the sound properly. Thank you.
Can one person change the world? Can one person really make a difference? Where would you even start? Following the devastating 1994 genocide in Rwanda, the country faced a critical shortage of trained medical professionals. Dr. Jeanne d'Arc Uwambazima was the only local anesthesiologist in a country of 10 million people. Without anesthesia, safe surgery is impossible. Too frequently, mothers die in childbirth, children suffer from treatable conditions. Trauma victims often live with disabilities and in extreme pain. Dr. Jeanne knew that training more anesthesiologists was key to changing the lives of countless Rwandans. CASIEF is a volunteer group of Canadian medical educators with almost 50 years of experience training physicians around the world to become specialists in anesthesiology. Dr. Jeanne reached out to CASIEF. Could we help develop a Rwandan anesthesiology training program? Starting in 2006, we worked together to create a curriculum. CASIEF volunteers then went to Rwanda to provide hands-on training, and Rwandan doctors came to Canada to advance their expertise. Now, more and more specialists graduate each year. Each of these skilled doctors will make tens of thousands of surgeries possible, and they will go on to train many others in anesthesiology, critical care, and pain management. CASIEF helped Dr. Jeanne transform access to safe surgery in Rwanda and change the lives of thousands of people. But there is still work to be done. With your donations to CASIEF, together we can improve the lives of women, children, and surgical patients in Rwanda and our other international programs. Yes, it is possible for one person to change the world. Sometimes you just need the right help.
I'm Bruce Coburn. Together, we can succeed in training desperately needed specialist doctors where they are needed most.
So I've left this less time for this part of the talk, but we'll definitely have some time for this in the questions. I think a really large part of the solution is to focus on important ways where we can actually strengthen healthcare systems as a solution to a lot of the problems that I've been talking about over the past 25 minutes or so. The genocide truly left Rwanda as a clinical desert, and it's really hard to imagine how a country could recover from that kind of situation without having really strong external partnerships. Oops. Sorry, I think okay, so I'd like to come back to this model of healthcare system building blocks, and partnerships to support education, I think, are a really important part of this. We focus very much on workforce, and I think the importance of focusing on workforce is that this is something that is never an easy fix. That to train specialist physicians who are going to be leaders in the future takes decades to get the program running and to make the program effective and self-sustaining, and is something that needs a lot of investment in as soon as possible. The other thing I'd like to say is that we focus very much on leadership. We're not really just training somebody to put in an endotracheal tube or to give some halothane or put in a spinal, but we're looking at people who will be leaders in their healthcare system in the future, who will make real changes and who will be change agents. We train people especially for leadership and expect them to be leaders in education where they can train many other people during the course of their career. Many of these other building blocks are obviously just as important. To some extent, we work with advocacy to try to improve things like financing and information and service and medical products. But these are for sure equally important things that need to be focused on by other organizations and by the healthcare systems themselves. So, as we said, our CASIF model aims to strengthen healthcare systems. I think one of the key things to do is to work with the public healthcare system and to work with government hospitals and government universities. Even within surgical care, I think there's often a type of exceptionalism where certain types of diseases and pathologies are preferenced above other things. In practice, fly in, fly out short-term surgical missions will often focus on things like cleft lips and palate, club feet, maybe neurosurgical disease or cardiac disease, but really have no lasting effect on the healthcare system. I think compared to partnerships where you invest in individuals within the public healthcare system that can stay in the healthcare system and train many other people throughout the course of their career and have a real change nationally, I think it's a very different proposition and something that I would encourage you to get involved in. So my second to last slide is maybe a little controversial. I'd like to show you an image of a joke from The Onion, which was at the height of the Ebola pandemic in 2014, the Ebola epidemic in West Africa in 2014. And The Onion suggested that the Ebola vaccine at that time was at least 50 white people away. And actually, they were not too far away from the truth, because when Ebola jumped from West Africa and started happening in other places, in particular North America, it wasn't very many deaths in North America before a lot of investment was made in the Ebola vaccine, which now exists and is being deployed throughout Central and West Africa for epidemics there. There's a parallel here with the pandemic and the amazing scientific advances that produced so many vaccines so quickly for COVID. And I think that the international response to COVID in many ways has been amazing, although obviously we're very worried about vaccine equity and about how things are progressing in countries like India and the poorest countries in the world. But I think we should not lose sight of the fact of the underlying chronic, day-by-day, year by year, decade by decade problems that, that underlie the pandemic, that underlie so much of the harm from the pandemic and so much of the collateral damage. These things have only got worse with COVID. We need to think about how we can build back stronger after the pandemic, as well as dealing with the problems that we're looking at now. And surgical and obstetric and anesthesia care is such a fundamental part of healthcare systems, such a fundamental part of the global burden of disease. I think that we all have a huge role in helping to support those healthcare systems. And honestly, if it's not us who's going to get involved and do it through partnerships, then who is? Thank you very much for your time, and I'd be delighted to take any questions.
Well, thanks very much, Dylan, for sharing your presentation and your thoughts and your passion with us this morning. You've really given us a lot to think about, a lot to chew on. We have asked people to post questions in the chat. So if you're able to do that, Dr. Wong and I will try to curate the questions. We have, it's about just before 8 o'clock now. I suspect that some people will be dropping off because of a need for other commitments, and that's fine, but we will probably have about 10 or 15 minutes for questions. And while you guys are all writing your questions, I just want to give a little plug to the Bethune Roundtable, which is happening, I guess it's next weekend, right? May 28th to the 30th. This is a Canadian conference in global surgery. And this year it's being facilitated through McGill. And the topic is strengthening health infrastructures in under-resourced communities. So really dovetails very well with a lot of the issues that Dr. Bold brought up in his talk today. And if I can turn the podium over to you to ask or forward on the questions.
Yeah.
Thank you. Dr. Bold, I just want to echo Joel's deep thanks to you for a very eloquent, very impactful and very inspiring presentation. Really appreciate it very much. We do have some comments, looks from Dr. Brian Cameron about McMaster's education partners, including Uganda and Guyana, with clinical fellows coming to Hamilton, sponsored by St. Joe's International Outreach Program. And he's left a link for donating to the program that McMaster supports. We do have a question here. What would be your suggestions to trainees on how we may best prepare ourselves for engaging and improving in healthcare provision in low resource settings when we primarily train in high resource settings? So, or is this is there a place for residents who have, been accustomed to training in high resource, or is this best done when they're finished their practice? What's been your experience?
Yeah, I think this is such a good question. And so many residents across Canada are, and in fact, across the world are very passionate about global health and really want to get involved. So I'm glad that it's been asked. So we use residents a lot in our programs. In fact, we have a global health fellowship in Zambia that we've started recently in Ethiopia, where we have very senior trainees who spend between 6 months and a year in Zambia or Ethiopia, working there as part of a global health fellowship. And these senior trainees just have a huge impact, especially when they're able to spend a little bit longer in country. We find that a lot of time staff can only really spend a month, which is still a long time in country. And it's very difficult to maintain continuity if somebody's only in the country for a small amount of time. It's better if they keep going back year after year, but a short visit is challenging for really understanding the situation, the context, and getting continuity. There's definitely challenges for people, and not just for residents, but for anyone going from a high income setting, if they've only ever practiced in a high income setting, to going to a low or a middle income setting. I for sure found these challenges. Advice that I would give you is go out as a resident with a staff who's done it before. So make sure you go out fully protected so that you're not really responsible for any care yourself, that you get to learn a lot. And don't go out with the expectation that you're going to save the world. Go out with the expectation that you're going to learn a lot of things and you're going to learn from your partners. I, for sure, have learned as much from my partners in Rwanda and Zambia as they have learned from me. There's some really strong clinical lessons to learn there. There are courses you can do. There's an anesthesia global outreach course in North America that hasn't happened with COVID, but I think we'll be back soon. There are other courses. There's one that's in Uganda, there's one in the UK, one in Australia, which I think are really useful to get into grips with some of these issues. But I think really the main thing for me is that these programs work best if they are true partnerships, where you are spending a good amount of time in country, trying to walk in someone's shoes, trying to live the same life that they do, spend time in the operating room with them. You can't just teach in the classroom. You have to know what things are like in the intensive care, in the operating room, on the obstetrics ward. You have to know the clinical reality day by day, on call at night, during the day. Otherwise, you can't really hope to deal with the situation. For sure, I think, trying to take some slides that you've used in a presentation here in Canada and just teach them indiscriminately in other places around the world as if the context is exactly the same, it is really a recipe for wasting your time. But I think meaningful long-term partnership is a way that we can all learn together.
Okay, thank you very much, Dr. Bull, for that. Dr. Cameron's asked, could you comment on the training partnerships in Guyana and Uganda?
Yeah, I think, thank you, Brian, for bringing that up. I know less about the partnership with Uganda, although I've heard a little bit about that. I think the partnership with Guyana, which McMaster is leading, is a really, really great example of the kind of partnership that I've been working on. It's a combination of volunteers going over to Guyana to work there, but also bringing residents to come over here to learn skills that they can't necessarily get in Guyana, which will both be clinical skills, like maybe experience in neurosurgical anesthesia or thoracic anesthesia. But I think probably most importantly is seeing a really high functioning healthcare system and seeing what is possible when you're in a healthcare system when everybody is really at the top of their game. And I think that combination of having people come to Canada and Canadians go and work in country is really strong. I think other really key elements of the partnership that work very well is that it's a long-term commitment. You're not just flying in and out for a week, you're going there for a month, and hopefully you'll plan to go back, if not the following year, then keep going back multiple times. And a lot of our volunteers that have gone to places like Guyana or Rwanda have gone like 6, 7, 8, 9, 10 times year after year. I think the first month that you go is mostly learning on your behalf, but you go back the following year, and then all of the time after that is gold, and you're really, really adding value because people know you, people trust you, you understand the local context. So I think that long-term commitment and that trust and relationship building is a really important part of these relationships also.
Great. This is a comment from Dr. Jean to thank you for sharing this morning and the emphasizing on leadership being very important. It's really key to ensuring the retention of the vital trainees within their own healthcare systems. You're not just simply training technical people, but those who can lead most sensitively in their own country and healthcare system to a better world. So lots of applause for this sustainable approach.
Do you mind if I pick out one of the questions?
Oh, absolutely.
Yeah,
absolutely.
There's quite a lot of questions from residents, but we have a resident session afterwards, so I can focus a lot on how residents can get involved in global health in that session. So maybe I'll neglect those questions here at first. But there's a question I think is from Alex Dauphin, which is about how you measure success with our perspective or their perspective. And I think this is such a great question because one of the things that we've been struggling with and trying to learn about through all of these partnerships that I've been working with throughout the last 10 years or so, usually comes under the umbrella of monitoring, evaluation, and learning. So how do you learn yourself from the partnership and grow stronger as an institution, as a charity, as a partnership? How do you monitor what you're doing and make sure that you're keeping track with goals? And how do you evaluate the whole program, which includes being sure that the goals are the right goals in the first place? And I think it's super challenging, but I actually think that Alex has hit the nail on the head with our perspective or their perspective, which is our goal, certainly when we started in Zambia, and I think this has been the same in all the programs I worked with, our kind of primary guiding principle is to make ourselves redundant as soon as possible so that we can be supportive partners if needed, and an ongoing relationship if that's of mutual benefit, but unnecessary to develop the anesthesia training program or whatever training program it is as early as possible, and to develop strong local leadership and to have ongoing goals defined and revised by the leaders that we've trained. And the people we've trained through the programs in Zambia and Rwanda are now heading departments of anesthesia. They're heading their national societies. They've been involved in things like a big thing post the Lancet Commission on Global Surgery, a national surgical obstetric and anesthesia plans, where a country will get together and make a plan for the nation or sometimes for a province, which is a roadmap from getting from where we are now to where we need to be. Like, how can we get on top of trauma care, maternal mortality? How can we sort out these key indicators that include mortality and harm and disability coming to patients? And the people that we've trained through the programs have been involved in these very, very high level processes involving the government and Ministry of Health to figure out national strategies. So I think for me, there's proximal successes which mean a lot to me. So when I see somebody graduate from their residency program, when I see them working clinically with an excellent standard of care, when I see them training other people, it's obvious to me that that's made an impact. And for me, that's the joy. And you can see the return on investment. And I can see that someone like Masuzio, who I showed you earlier on, I just know that the impact that he has throughout the course of his career is going to be incomparable compared to any volunteer that bowls up in a country for weeks or months. But on a broader kind of system scale, I think we need to be, to have some really good indicators for success. And this really needs to be done strategically on a national level. And that has to be driven by local leaders, which is obviously a challenge if you don't have any physician anesthesiologists in the country. Like if you have one in the country like Rwanda after the genocide, there's no people to do that. So I think you have to train them first.
Thank you. I think we have a hand up from Dr. Bruno Borges. So if it's okay with you, Dr. Bullock, can I let him jump in here?
Absolutely.
Hey, Dylan, how are you?
Yeah, good to see you, Bruno. How are you?
Yeah, long time no see. Thank you for inspiring one more time in my career to do something, meaningful. When I look at your slides and how things are in there, one thing, like coming from a place that it's not, that bad, I would say, but knowing how different and shocked, sometimes I go back to Brazil and sometimes I am a little bit shocked even with things that I still see. And when I think about going to Africa and help, I always wonder, am I going to be okay? Right. And what would you say about that? And is it this 1 month sort of endeavor? Is it a family thing that you can do, or how easy would it be to get involved with it?
Yeah, I think it's a great question. I think that for there's a couple of things there to unpick. I think the first is, as you rightly said, like Brazil is a middle-income country and definitely has its share of problems, but it's another level when you go to places like Zambia or Rwanda. We send our trainees when they're finished graduating to countries like South Africa and Brazil and India to train for further specialist training, because we know that the healthcare system and what the training available is significantly better in the kind of like upper middle income countries than it is in places like Zambia and Rwanda. And for sure, it can be tough. I would say, especially with our global health fellows who are out there for 6 months or a year, there will be some pretty dark days, usually in the middle of that period of time, that take a lot of debriefing. It's very, very hard to see negative outcomes where you know that things could have been done better. And it's really, really hard to see them in young mothers and in even young men and children. And there's definitely some real challenges there. I think that we try and do our best to support volunteers when they go out and to debrief afterwards. But it's definitely not easy. And I think that you have to go into it with your eyes open, that you'll see a lot of difficult things, but I feel like it's balanced by the fact that you see so much change and so much real meaningful change. And the things that you see, you know how many lives are going to be saved by an obstetrician, a specialist obstetrician that moves to a rural area, or by a specialist general surgeon who's going to mean that people are having safe laparotomies, not unsafe laparotomies. And it's you know, not a family doctor, a general practitioner doing the laparotomies, or safe anesthesia. I really think it balances it. I think on balance, looking back and reflecting, you know, you get much more joy, and you get much, like, honestly, I would say, Bruno, that this work in my career has prevented burnout for me. It's really meant that I can go renewed to my job in Ottawa, grateful for what I have, and really feeling very lucky. I think the other question is about, like, kind of logistics and, you know, should you go out with your family? I think you absolutely can. I mean, I think if you're going for a month, then maybe you're going to be quite busy. And unless your family has something else to do, like, I know people who've brought their family out and they've seen their family in the evenings and the weekends while their family have done some sightseeing around Kigali or around the surrounding areas. And I think a lot of people have really enjoyed having that kind of support. Our volunteers are busy during the day and usually want to stay late and deal with situations. I went to Rwanda for a year, so 2017 to 2018, I went to Rwanda for a sabbatical year, and I was the program director of their residency program, and I was twinned as the associate chair of the Department of Anesthesia, Critical Care and Emergency Medicine to support their academic mission. And I brought my family, I brought my 3 daughters and my wife, and it was amazing. We had the best year away together, exploring a new country at weekends and on vacation. And it was also amazing that my family could understand a little bit more about what I did when I go away to these places, and could become a little bit more invested in it. I think it made a real difference. Sometimes when you go away and you come back and you've had this big experience, and it's very difficult to explain to somebody what actually it's been like. So when they were there in the country with me, it was real for all of us. So I think there's definitely opportunity for that. And if anybody wants to get involved in these programs, like, please feel free to reach out to me. Joel can share my email address, or indeed to reach out to Joel, who's very familiar with the program in Guyana in particular.
Great, thank you. So we do have 2 questions regarding residencies and fellowships. Did you want to entertain those, Dr. Bold?
Yeah, I'm just seeing that there's a 1-minute warning. So I'm just wanting to check in with Joel. Should I deal with those questions about residency in the resident session just shortly afterwards?
Dylan, I think if you can briefly address them now, because there's a potential that these may not be anesthesia residents asking those questions.
Yeah, absolutely. Yeah. So, I mean, I'd say there's a couple of questions. So I'm not aware of any residency program when it's expected to do a rotation overseas or in underserved areas. And I think that underserved areas is really important as well, because we have plenty of underserved populations right here in Canada who also need some serious thought about an investment, although the problems are obviously not exactly the same. I would really strongly advocate that it should be core learning for every resident to understand about global health equity. I'm not sure if every resident needs to do a rotation overseas in a low-income country and a lower middle-income country. And I'm not sure that needs to be mandatory, but I think there are many ways that you can learn about it and contribute even from here. And some residents do amazing work contributing from here and learning about the situation. There's a question also about fellowships. And I think that's also a really great point. There are increasing numbers of global health fellowships. We have a global health fellowship in Ottawa that we've just recently started. We have a new global health fellow in anesthesia starting in a couple of months' time. At CHIO, we have a global health fellow who can be from any specialty, from the Children's Hospital in Ottawa, could be from surgery or from anesthesia, any kind of pediatric specialty. There's an anesthesia global health fellowship in Dalhousie, which is very well established and has been really successful. In the US, there are a lot of fellowships that are much broader, who include anesthesia and surgical and obstetric care. I would say probably like the leading light is the PGSSC in Harvard, the program for surgery and social change in Harvard, which is a really fantastic program led by John Mira and his team. But there are many others. UCSF has a fantastic program, and they're having a newly developed Center for Global Health, which is focused on perioperative care, which is surgery and obstetrics and anesthesia together. So I think that a lot of people are trying to get value from their fellowship that will help them in their future career, as well as help them follow their passion. And a lot of these fellowships enable you to really get a great network, to start an academic career in global health, to think about research, quality improvement, monitoring, evaluation, think about how you can disseminate and publish some of these things in a scholarly way, and really set yourself up to use this throughout a career. So I didn't do a global health fellowship, but I would strongly recommend that to anyone who's passionate about this, consider one of these fellowships. I think you'll get a lot of value from it, and it will really help.
That's great. Yeah, I think.
Great.
Yeah, I think we're close to the end. I don't see any more questions, only accolades in the chat.
Thank you.
So yeah, so I think we can bring our rounds to a close. I want to thank you so much, Dylan, for joining with us this morning and for sharing your passion with us, and for inspiring and encouraging all of us to think about ways that we can get involved. But even if we aren't particularly involved, to develop that social consciousness and that awareness of what is taking place in the world around us. And so thank you very much for doing that. One other housekeeping thing to mention, David will be sending out an evaluation for today's round. So if you can please fill that out and let us know, that helps us for planning for next year. And I think that was all of the things that I had to mention. So thank you very much, everybody, for joining us. And yeah, if you want to get connected with MacGlObAS, you can just do a Google search. It'll come up, and our newsletter will be on the website. There's ways for you to register to receive our regular news updates, and certainly feel free to reach out to any one of us. Our emails are listed there if you're interested in learning more about the work that we do. So again, thanks everyone.